Yeah, debate. We're going to be, kind of taking is long COVID, is it really this new condition, or is it just another post-viral condition? So I'm taking it from the perspective of, this is another post-viral condition, and these are, maybe that's not fully my true, debate side, but, this is something that I'm gonna talk about today. So when we think about the pathogenesis of PASC, the post-acute sequela of SARS-CoV-2, and as we're learning it, we see that, there is viral antigen persistence. And we know in other viruses there's persistence as well. That's why Epstein-Barr virus can be reactivated. And sometimes in long COVID patients, Epstein-Barr is reactivated, and that's what's driving their long COVID. So again, it could be viral antigen persistence or reactivation. There are inflammatory markers, and again, that can happen with any kind of inflammatory condition, autoimmunity, that's driven by infection, and then microthrombi. And all of this leads to inflammation and abnormal biomarkers. And that can be, like I said, it could be this can happen from other post-infectious disease syndrome. So which is why long COVID is very much like another post-infectious disease. And this just shows like, what's the timeline, what happens, when do we have the test that's positive, when do we have the highest viral load, and even as it's going down, that patients are still having symptoms or sometimes even re-emerging symptoms 4 weeks or more later and lasting for 12 months, 12 weeks, 12 months. I mean, now people have had it since the beginning of the pandemic, long COVID. And what are the effects? So this is just a slide showing a meta-analysis of 50 long-term effects of COVID-19. And if you look at the things, fatigue, headache, attention disorder, hair loss, dyspnea, these are things that are seen in other post-viral conditions, especially the fatigue. If you think of, almost all patients that have ME, CFS, myalgic encephalomyelitis, chronic fatigue syndrome, started with an infectious disease that started their ME/CFS. And so that is why this is, and some of the patient population with long COVID do meet those criteria. So this is all you can click on. It's just like post-exertional malaise, and ME/CFS is important for us to know the Institute of Medicine definition. Because when patients that's the cardinal symptom of ME/CFS, which is going to be they just do activity that's their regular activity, and it causes crashes, and they have these cycles that are relapsing and remitting of crashes when they do activity that would previously be very easy for them to do. And so it's very important that we recognize this in long COVID, but we also see it in other post-infectious disease states and in ME/CFS. And so this is just a slide from an article that was in a newspaper. It was like, there have been outbreaks of other fatigue-related illnesses through the decades. So this is not the first time that we see a fatigue-related illness. It's been in, other parts of the country, several up to hundreds of people with it. Again, probably driven by some type of infectious etiology. And there is, post-SARS syndrome. So not even SARS-CoV-2, but the first SARS we had, there was patients, not as many patients got SARS as SARS-CoV-2, but these patients also had fatigue, depression, disordered sleep, and chronic pain after SARS too, so very similar. What other epidemics have we had, and then what's happened after those epidemics? So H1N1, SARS, just SARS, influenza, Ebola, West Nile, and these all have the long versions of this as well. There's there's a long flu. Did you know there's a post-Ebola syndrome? And, we know West Nile encephalitis, can cause issues as well. These are just, more, 64% of fatigue with SARS-CoV, with the first SARS, ME/CFS happening in H1N1 and in other types of disease states as well. Yeah, post-Ebola syndrome, fatigue, muscle and joint pain, sleep disturbances, same things that we're seeing. And West Nile, 31% had fatigue in 6 months. So again, all the chikungunya, I mean, there's ones that even aren't on here that cause very similar symptoms as well. And so these are just more, again, articles saying, okay, we know there's an inflammatory response in post-viral illnesses. We know there is chronic fatigue syndrome after post-viral illnesses. What's sad is that a lot of these post-viral illnesses have been underfunded. ME/CFS over time has been underfunded, and I think had we had funded more on this, then, if there'd been funding, we'd been way ahead on where we are right now with long COVID, because we would know a lot more about post-viral illnesses. We'd know a lot more about ME/CFS. And then these are just also non-viral infections cause similar things. So, Q fever, Lyme disease. Chronic Lyme is a thing, and causes, it's again just a post-infectious disease syndrome that can even drive ME/CFS and so many other neurological complaints, giardiasis, dengue fever. So even in non-viruses, we see these similar conditions. And this was my last slide that, this was on the Washington Post. This is something that's out there now, because there's a population, millions of patients who've had chronic fatigue, who are now seeing very similarities, who are seeing, a lot of attention being paid to long COVID. And they're like, okay, well, now that we have a little more attention and financials, NIH studies going into long COVID, hopefully it'll unlock more for a lot of people that have post-viral diseases and have been suffering for decades. And that was just something that the NIH is looking at it. So even I'm in the NIH, I'm a co-investigator in the RECOVER trial, which is a big long COVID trial. And I'm in a subgroup of experts in post-infectious disease. And so even we're trying to get a control group of patients who had ME/CFS before the pandemic to see if, there's some similarities or differences.
All right. Thank you, Monica, for your pitch. So you just heard what ME/CFS presentation is like and what other post-viral syndromes there have been so far. But I would like to have my opinion on how post-COVID is not just ME/CFS, or it's much more than that. And it's just not like any other post-viral syndrome. And I'll start with the magnitude of it. You mentioned it has been many other epidemics and endemics before, but the magnitude of this is like no other. And I have just some numbers here that I pulled recently. Worldwide, 632 million cases, over 6 million deaths. And just in US, 98 million cases with over 1 million deaths. So if you look that up in every state or the area you live in, you will see APM as a dashboard, which tells you how many cases you have in your own city or zip code, I think, district. So it's a totally different magnitude and nothing like we have seen ever before. And what this is there's different definitions of long COVID, post-COVID, or post-COVID conditions. Now CDC calls it as post-COVID conditions. But depending on whatever time frame and definition we follow, the recent numbers show that 1 in 13 Americans, that's 7.5%, 3.5% in UK, and 4.6% of Canadians. And these are not patients, these are just total population, have long COVID type symptoms at this present time. And these were, the Canadian one was just released earlier this week or last week, and the other one, the CDC released the US number a month back, and the UK was from a huge study that came out recently. So we're not talking about just patients, but this is entire populations of countries. And there's another study which shows 31,000 patients, and 42% of that had only partially recovered. So we have seen such conditions before, but not just this magnitude. So what is a post-viral syndrome is, it's a symptom of persistent symptoms after any viral infection, and if it's mainly characterized by fatigue, it's called post-viral fatigue syndrome. And previously, we've seen that this was common, like in SARS, in MERS, in some others, but the percentage was at the most 11 to 12%. But now, where I'm saying in the prior slide is 40%. Some studies showed 80% of the population that had recovered have not completely recovered. So there's something more than just the debility or just the non-specific post-viral symptoms that persist. This is more specific to the pathogenesis of this particular SARS-CoV-2. This is another study which looked at over 270,000 charts and survivors, and at 3 and 6 months, they had 1 in 3 of their patients had some symptoms. So what they said is this is very specific to the infection by the SARS-CoV-2 and not just a consequence of any viral infection. And these are the different systems that they included in their meta-analysis. And as we see, if you look at the ME/CFS picture, it's mainly fatigue, sleep, some cognitive symptoms, and the classic post-exertional malaise or symptom exacerbation after any activity. But this is way more than that. It includes psychological issues, encephalopathy, thromboembolic events, stroke, kidney, and pretty much every human system. And I'm just going to go into some of these systems we know and which are very specific to this disease because we have not seen this before. We know with in the pulmonary manifestation there is fibrosis in the severe ones, or at least there is some decreased diffusion capacity. And in population that has been studied, many patients with moderate to severe disease, this last study I quoted here, 25 to 65%, depending on moderate versus severe, had some form of pulmonary sequelae after their acute infection. And these are the moderate to severe patients, so we know the vast majority were mild, but if you still see these significant ones, this is very high in number. Similarly, cardiovascular effects. This was very rarely seen in prior. We did see some myocarditis in certain very few cases after flu or certain with Ebola, but again, it was very minimal. The rate here is striking. So there's evidence of myocardial injury from 7 to 40% in one study, heart failure from between 23 to 33% among hospitalized patients. So again, hospitalized at least is moderate to severe disease. And then RV strain and presence of arrhythmias in 18%. And neurological sequelae we know. I would just like to quote one study here which was done recently. They saw that even in mild COVID, there was changes in the brain, in the myelin, and there was elevated level of chemokines and cytokines in the CSF. So this kind of shows that this particular virus has ability to directly penetrate the blood-brain barrier, and even with mild disease, when there's no other systemic involvement in the acute phase, you can have these persistent CNS changes. And then the list goes on. This is common cognitive fog and autonomic dysfunction. So this, again, I would like to point out, the list of symptoms that we could attribute to autonomic dysfunction is pretty long. I've included a small list here, a quick photo here, but this was not very common before. Autonomic dysfunction, depending on certain surveys, have been seen up to 19% of patients that have long COVID. And it's actually 25 had dysautonomia, so they were not actually diagnosed, but they had some form of either exercise intolerance, drop in blood pressure, orthostatic intolerance, heart rate variability, or a POTS or neurocardiogenic syncope type of picture. So again, these are pretty high numbers. Headache is common, and olfactory dysfunction. One paper suggests that there's over 1.6 million US people in the US that have persistent olfactory dysfunction from COVID. Another study said 36% of their patients never recovered normal olfactory function, and they had either an anosmia or abnormal sense of smell. And then the psychiatric sequelae are also pretty long. So talking about all these, we know that the acute phase of the disease is manifested by different system involvement, which includes the lungs, and we've seen how the COVID-2 infects those based on the receptors. My point is, I think similarly in the chronic phase, it's not just debility, it's not just your lack of sleep, but it's something specific to the virus. All right, so I think the next part we're going to talk about, do you have, Dr. Bruce? Questions?
I have questions.
Yeah.
I have also have answers, but more questions.
Yeah.
When I see these, I only do inpatients, so when I see these people, they're sick enough to be on the rehab unit. They're not the outpatients who have various symptoms. And so they would come to us, for example, with what appeared to be quadriparesis, and sometimes. So my question is the post-acute syndrome felt to be due to the fact that the virus is affecting all kinds of organs, not just the lung, and that you can have it affect your brain, your kidneys, your nerves? Is that what's going on? Or is it a secondary thing where that you have hypoxia and metabolic encephalopathy, and that produces damage to others? Is it primary or secondary?
I think it's primary. I don't think it's a primary lung disease per se. I think there's endotheliitis, and then it gets everywhere in your body, and it's almost like a chronic immune-related vasculitis, almost. It can, impact so many different parts of the body.
So just like anything else, it can affect any part of your body.
It can affect any part of your body.
The second question was, some of these patients, I've seen a few patients in my time, and I was confused by them because, like the guy who comes in with quadriparesis. The question is it post-COVID? Is it Guillain-Barré syndrome from a viral infection? Is it critical care neuropathy? What is it? And unfortunately, even if you do an EMG on these people, the EMG doesn't come up with a text message that says this is this. It's still confusing.
I think for the severely symptomatic acute severe disease, I think it's all that plus there's something more. So for example, you mentioned someone with quadriparesis. It possibly could be critical illness myopathy or polyneuropathy, which we do see, we have seen it before, but I think it's much more pronounced due to the specific virulence or either vascular dysfunction, endothelial dysfunction, or something else. But I agree, in the acute phase, I don't know how would you distinguish. I mean, like you said, nerve conduction is not.
I'm used to it now, so we send it to physical therapy anyway.
Yeah.
Right, exactly. We know how to treat it now, so that's a good part.
Exactly which one it is, but.
Yeah, the patients, I think there's more and more data now on patients who were hospitalized with COVID and that they do well with inpatient rehab, and so we need to continue to rehab those patients, the traditional way. And so there is now more and more data for that. It's just the ones who are the mild ones that now have the kind of the long COVID syndrome, the fatigue, and the ME/CFS, that those patients need to have a little bit more. They have to pace themselves and can't do, the traditional model of rehab.
Well, the patients that I have had have generally not done well, not because I was their doctor, but because they instead of going home, many of them were elderly people to start with. Then they have 3+ strength, 3+ over 5 strength. It doesn't improve. At least it doesn't improve in the short time they can have them on rehab. They end up sending them to the nursing home. I don't know what happened to them after that, but it seemed like a very long haul.
Yes.
Okay.
All right.
Yeah. So the next question we're given as our debate topic was like, who should be the leaders in long COVID? Obviously,
We should,
right? The answer is we should, right? So we're just taking, different
Two
stances on this. So I'm saying, of course, physiatrists should be the leaders of long COVID care. And, we all love physiatrists and what we do. And so I think, I don't have slides related to this, but, I think, it really struck me, Steve said the other day, he's like, what is it that we own that no one else owns? Disability. And it was a fresh way of thinking, like, I thought he was going to say function, or we knew that's our organ, I guess, but we deal with disability, and this is one of the largest mass disabling events that we've seen in a really long time with this pandemic, both for people who had very severe hospitalized, but also ones who are not very severe hospitalized, and their fatigue is significantly debilitating and keeping them out of work, or their POTS are keeping them from standing up and doing those kinds of things. And so I feel like we are the best specialty because we train in looking at a patient holistically and looking at their mental, physical, cognitive, the combination of those things, and vocational to get them best outcomes. And we've taken care of patients across the spectrum. We take care of patients in the acute care. We take care of them in the outpatient care. We've had patients with autonomic dysfunction before, and know there's a specific type of rehab for those patients that's different than a traditional rehab program. And we can deal with cardiac pulmonary rehabilitation patients, and we know how to do the EMGs on the patients who have critical illness myopathies and polyneuropathies, and so that is kind of my reasoning that I think. And we lead multidisciplinary teams. So I think, it has to be multidisciplinary, but PM&R needs to be involved in it and needs to be the leader of it.
But there aren't enough of us.
But there's
Exactly.
that was
So
asked as part to do
I
it.
have a question later, go ahead.
yeah, so exactly. I mean, I hear you, Monica, and I agree to it that we definitely need to be in the forefront of this with advocacy, leadership, developing guidelines, and really helping the other care team or education and other care providers. But I think, like Dr. Bruce mentioned, there's just not enough of us. And I just have some data here which tells us the same thing that I'm talking about. If you look at the number of people per physician, the ratio, PM&R has it on the website. This data is from the AAMC. We are somewhere around 10,000 physiatrists in US. And the most recent population is 331 million for the United States. And that leaves us to 33,000 and almost 34,000 patients per physiatrist. While if you include the primary care, family medicine, geriatrics, med peds, and peds with all ages, and looking at they are the primary care doctors, the ratio comes down to 1,000, little over 1,000 patients per physician, which seems a little manageable, especially when looking at the magnitude of this problem, which I just mentioned in earlier part of my talk, where we have millions of patients still ongoing with long COVID. This is a great infographic from an article that was recently published in the BMJ last month, and it talks about it's a guideline for the primary care providers in UK and across the world really. And this infographic tells you what a primary care doctor can do. They have listed some common symptoms, they have listed some red flags, and then based on the red flags, they have just shown what should be done. So I think this is where we probably should get at. And what is the role of the primary care provider here? And these are some of the highlights from the same article. Is most important, we have seen over and over across multiple other sessions as well, hearing the patient, validating the patient, educating the patient, telling them about either the uncertainty of diagnosis and prognosis at this time, but in the same time, helping the patients to improve, monitoring their progress is, I think, the key here. So we cannot do that for every individual who is suffering. So I think we need to educate the primary care providers here. And similarly, there's some other stuff, managing the comorbidities. Primary care can certainly do that. Diabetes, we know, mental health issues, sleep issues are really big comorbid factors which are not responsible, but are definitely preventing improvement or recovery for this patient. So management of these is very important. And what I'd like to propose is this tiered approach. Again, this was through a nice article that came a few months back, and this is based on the nice guidelines that were released in the UK, and they have a tiered approach where the level 1 or the top tier is their multidisciplinary team. And probably that's what we are trying to get to here is centers of excellence. There's the White House memorandum that came out that they're trying to fund and create centers of excellence. Yes, I think this is where physiatry should be. We should create, we should direct, we should manage the centers of excellence or the top tier. But we cannot be at the bottom because we just don't have enough really bandwidth at this time. So they have a very good approach here with a 3-tier, with starting with primary care, with based on symptoms, they can refer them to education and guidelines and self-management at home. Secondary tier with some community, other physicians, including some therapy modalities here. And if the symptoms are not getting better, or we see some red flags, or we see worsening, then these patients should be referred to a multidisciplinary center of excellence. We both have long COVID clinics in our health systems, and we both know that by this time, actually even last year, our wait times have gone up significantly. We cannot get patients in 3 months and sometimes even longer. So I think that is the reality right now. Pre-pandemic, I think we wanted all our patients to get in right away. I used to see concussion. My goal was to get acute concussions within 2 weeks, but because of COVID and long hauler clinic, my concussion patients are not seeing me right now either because my clinic is completely booked. So I think that's the reality, and however we tried, so how we can improve is this, the AAP&R Long COVID Collaborative, create guidelines, educate the other primary care providers. There's some avenues for there, like the CDC COVID and long COVID ECHO projects, which some of us are experts in. We are talking and giving lectures to community providers in certain areas of the country. Other calls and the advocacy and legislation changes and some other guidelines that are out there already, like the NICE guidelines or the ones that are coming up from Australia and New Zealand for their own physicians. So I think this is what I would recommend is probably the ideal setup for treatment.
Is there a dichotomy between fatigue and brain fog?
So I feel I'm getting, some of my patients I'm sending to neuropsych testing, so I can really see what this brain fog is for them. But a lot of times it's the issues with concentration and multitasking that's very hard for someone to handle. So if they're in a room and 3 people are talking at a time, they're gonna miss things and they're not gonna be able to concentrate or not know what's going on. So I think kind of the brain fog is some of that, the attention concentration deficits, but I'm seeing that I also have some percentage of patients that are just being called brain fog, but may had risk factors for dementia and now having rapidly declining cognition and very much, meeting the dementia criteria, more than mild cognitive impairment. But
Yeah, I mean, majority of times I do see them together, but like I said, there are some people that specifically say only difficulty with attention, processing speed, and short-term memory, and they do not have the fatigue. I mean, fatigue is very common, but there is a small percentage which is totally different.
Can you separate them out by testing, like the mini mental test and many other tests of cognitive function to decide whether it's just brain fog or whether it's actual something else?
So a lot of times what I have seen is the MoCA and mini mental testing is normal in some of my patients. There are some ones which are like really impaired, and yes, especially the severe ones which had some acute hospitalization and course, but a lot of the mild ones in my clinic, a lot of it is normal, but yes, with neuropsych testing and a little more detail like slumps, which was mentioned earlier too, you can get a little bit, some impairment out there, but otherwise.
Is there any model that, I know you guys are not very old, but we've had a lot of things happen to us in our lifetime, and we've had, for example, the post-polio syndrome, and the way we handled that was we didn't try to take over their care. We didn't want to ruin their blood pressure medicines and making sure they have mammograms and doing their colonoscopies. We just wanted to be a consultant about their post-polio. That was a model of care. Is this a model that you can use for post-COVID?
it would be. I know that the VA, where there's a little more resources, they're trying to come up with models. I know there's other like very resourced centers that have multidisciplinary clinic models where PM&R is definitely involved, and is like at Johns Hopkins where there's like 10 different specialists and a case manager and working side by side. Overkill, right, overkill.
I mean, we published a paper with models of care,
Yeah,
right?
we
In
did,
that,
yeah.
we did have one example where physical medicine rehab was kind of a specialty, and it was through their family medicine, Hennepin Health. And based on their certain screening, only certain patients were referred to physical medicine rehab and not every patient. I think it's just because of the way their clinics were set up.
Is there a specific therapeutic approach to the post-COVID chronic fatigue syndrome than MECFS in terms of rehabilitative approaches to that? I mean, rehabilitative approaches to the former of the MECFS are varyingly successful. I mean, it's a question as to how hard to push, when to back off, what to look for in terms of signal metrics.
Yeah, I think that physiotherapists have had to really change their mindset on these types of patients, that it's not the typical graded exercise therapy, it's not the typical let's push you, because they're going to push and they're going to crash and they're only going to get worse. And I've seen that in a lot of my patients if they go to traditional therapy models. And I think some of it's learning, like, okay, we're going to start with the basics, like breathing. How are you breathing? Are you hyperventilating? Let's just start building your inspiratory muscles and teaching you things to do at home. And the other thing is like the energy conservation therapy, really teaching them about the energy envelope and learning, like, okay, this is how many steps you can do today. And now we all have these fancy watches that can tell us our heart rate and can tell us our how far we've walked, and teaching people those signs, like, oh, look, when your heart rate starts going up, you need to stop doing an activity, or don't reach over 6,000 steps, so you're gonna be in bed for 2 days. And I think we have to kind of frame their rehab that way.
I think it becomes a real issue, in terms of, I mean, heart rate is such a, poor proxy for, actual conditioning status, because it depends on stroke volume and cardiac output and all of that kind of stuff, and it also plays into, autonomic variables like heart rate variability.
Right.
I mean, probably the watches in the future, I would guess that Apple watches, my Garmin, basically at this point, theoretically is watching heart rate variability, but it does so really in a very inefficient and inaccurate manner. But I think looking at heart rate variability as a metric for cardiac function probably will play a larger role in the future, and maybe will become increasingly important as we understand how that changes with respect to post-COVID.
Yeah, on the point before about ME/CFS versus normal COVID, what we are doing is we are trying to see if there is any real indication like this post-exertional malaise and crash. If we see that during our physician evaluation, instead of sending them to the regular physical therapist, we have created an occupational therapy-based program where mainstay is activity tracking, energy conservation, learning the signs that your body is giving as to when to stop, and they get a diary of logging in their symptoms and their activity, and that's what the occupational therapist is doing. Once the occupational therapy actually feels comfortable that this patient is educated enough to monitor their own signs and symptoms, then they get discharged with a home access program, or if they are capable, then they get enrolled into a PT program, and then we can start some of the reconditioning. Obviously, again, not to the point of fatigue, just sub-maximal type of activity.
So are you guys supposed to be on opposite sides of the issue?
Yeah.
Yeah. So we're supposed to.
Forget that for a moment.
It really isn't an opposite.
What's the answer? How do we? I personally am not going to be doing people's primary care because I'm not trained in that. But I view myself as a consultant, like any other condition. When a doctor sends a patient to me with back pain, I tell them do this, do this, do this, and maybe treat them for a month and then send them back. Do I have enough time to take over their care? And will the doctor ever send me a patient again if I take over their care?
We don't have enough time to take over their care, because then you get boggled down with all the inbox messages and the forms and everything else. So we don't, but then they're happy to say, here, take care of this patient. Of course, I am like, oh, I don't know all those new diabetes drugs and all those, that they've come out with since even I was in training. And but I do feel that I still have a good holistic view of patients. I had someone recently that saw me on telemedicine from California, and she's like, I just don't want someone to put it together and tell me if I've had all the right workup yet, because everyone else was working in silos. And it was like she'd seen cardiology, she had autonomic dysfunction, pretty much POTS after having COVID. And so she'd seen cardiology and she'd seen neurology and she'd, done this and that, but no one looked at the whole picture. And, I can kind of look and said, okay, you've had, just because now I know more about long COVID, say you've had this, I think the only thing you've missed is you haven't had antibodies checked, because in some cases, some people develop an autoimmune autonomic dysfunction. And I said, and if we check that and then it's fine, then, continue what you're doing and you're starting to get better and continue to hydrate yourself. And that was like, okay, she was happy and I could hand it off back to someone else.
I'll tell you what my fear is about COVID. I think we'll eventually let COVID. It may take I plan on taking a shot twice a year, probably the rest of my life, for COVID, because the COVID virus keeps evolving and mutating. But was it something I said? I didn't mean to break
No,
up.
I was just thinking.
And then, what I'm afraid of is that there's some sequel. Like people get chicken pox and you're over it.
Yes.
And then 30 years later you get shingles.
I said that. I said, post-polio didn't happen for 4 or 5 decades later. What's going to be post-COVID?
That's my.
Now we know Epstein-Barr virus, one of the main risk factors of multiple sclerosis.
If it doesn't kill you now, it'll get you later.
It'll get you later.
That's That's my fear, is that it has some delayed sequela.
Yes, right, like, is it living inside your cells, is it, right? Yes. All right, I have to go already to my next meeting, but
Thank you, guys.
thanks.
Thank you very
I wanna
much.
Thank you very
You're
much
welcome.
for participating in this and